Good afternoon, and thank you for joining us. The session will begin in exactly 5 minutes. Thank you.
Okay, I think we're going to go ahead and get started now. Hello and welcome. My name is Catherine Chung Bridges. I'm the Director of Research at Health Choice Network. Today, we will hear about a successful research project that was done in collaboration between CareQuest Institute for Oral Health and Health Choice Network. This has been an amazing partnership between CareQuest Institute for Oral Health and Health Choice Network. We are like-minded institutions mutually concerned about the health of our community. The CareQuest Institute for Oral Health is extremely visionary in their conceptualization of research projects, but they are also movers and shakers who get things done, and their work has high impact. So first, I'm going to introduce Dr. Sarah Raskin. She is an assistant professor at Virginia Commonwealth University and a frequent collaborator with the CareQuest Institute for Oral Health. Dr. Raskin conducts mixed methods, community-engaged research, which means both qualitative and quantitative methodology, on dental safety net policy and practice to advance oral health equity and racial justice. She is a 2020 recipient of the Wilder School Award in Mentoring and a board member with the Association for the Anthropology of Policy. Dr. Raskin's research has been funded by the Virginia Commonwealth University Center for Clinical and Translational Research, the National Science Foundation, the Agency for Healthcare Research and Quality, or AHRQ, and Patient-Centered Outcomes Research Institute, or PCORI. Vu Diep is a health science specialist who is responsible for managing and coordinating the development and progress of analytical and research projects at CareQuest Institute for Oral Health. She contributes to the development of publications, posters, and other presentations. Vu also works with marketing, communications, and public affairs to develop creative materials and facilitate the publication process. She received her master's in public health from the Massachusetts College of Pharmacy and Health Science University and her bachelor's of arts in mathematics with a concentration in Asian studies from the College of the Holy Cross. Dr. Shelley D. Taylor is a master in public health candidate at Harvard University T.H. Chan School of Public Health and a Joseph L. Henry Oral Health Fellow in Minority Health Policy. Currently, Dr. Taylor serves as the interim dental director of Upham's Corner Health Center in Dorchester, Massachusetts. Dr. Taylor is the recipient of the 40 Under 40 National Minority Quality Forum Award, Outstanding Leadership Award at Broward Community and Family Health Centers, and the Young Alumni Gator Great Award. Dr. Taylor earned her Bachelor of Science and Doctor of Dental Medicine degrees from the University of Florida. She also earned an Advanced Education in General Dentistry certificate from the University of Tennessee College of Dentistry in 2016. I want to give a hearty thanks to Dr. Raskin, Ms. Diep, and Dr. Taylor for participating in this session today. I will now turn it over to you, but to the audience, I do want to mention, please, as we're going along, feel free to put your questions in the question box because we will have some time at the end when we will answer your questions. So please do that during the course of the presentation as your questions come up. And thank you so much. I'm going to hand it over.
Thank you so much for your introduction, Dr. Chung. So Vu and I are just extraordinarily happy to share with you some findings from some research that we've been conducting in partnership with HCN affiliated clinics. It has been a very rewarding experience, and thanks again for your hospitality today. It's really meaningful to us to share these results with you. Next slide, please. So the COVID-19 pandemic affected dental health service delivery Oh, thank you. The COVID-19 pandemic affected dental health service delivery in 2020 and 2021, as you all are probably aware, and is anticipated to permanently change oral health care in the U.S. and worldwide. And this is true for both dentistry overall and for the dental safety net in particular. So, for example, for dentistry overall, the airborne and droplet transmission of the virus created unique risks for patients and providers that was really above and beyond conventional infection control to this point. It also resulted in concerns about revenue loss as a result of those temporary shutdowns and service restrictions, as well as patient reluctance to return to care after reopening. And it goes without saying that provider stress and burnout has been very real across the entire dental industry. Also, early evidence indicates that some dental patients experienced worsened oral health conditions, in particular during the pandemic's initial stage, in part as a result of foregone care. Among the general population, this meant pain, infection management using oral antibiotics that was going on longer than is conventional with that treatment approach, the delayed repair of broken restorations, diminished home hygiene as a result of depression, and the carcinogenicity of coping mechanisms such as alcohol and sugary foods, leading to increased risk of early stage caries. But these risks were particularly concerning for dental safety net patients who, as a result of being low income, uninsured, resource insecure, and often excluded from conventional care mechanisms as a result of social determinants of health, such as housing insecurity, resource insecurity, and systematic racism, they tend to have worse overall oral health and oral health-related quality of life, and therefore need dependable opportunities for care. And so in this way, the dental safety net is a particularly concerning topic of interest. At the same time, dental safety net settings had to respond to the paradox of revenue concerns, which were heightened by their thin operating margins, and in many cases, new patient volumes due to the economic fallout of the pandemic, in which many unfortunately lost jobs and insurance coverage. These considerations were particularly fraught in the first year of the pandemic, as knowledge about the microbiology of the novel SARS-CoV-2 virus and its transmission, the epidemiology of infection severity and mortality, effective prevention measures, vaccine development and distribution, and other concerns were being determined and refined at a rapid pace, and federal relief was both slow to initiation and really serpentine to navigate. So this is kind of the background context of our study. We were curious to know, how did providers experience, respond to, cope with, and really process the implementation of care, dental care, and oral health service delivery during the COVID-19 pandemic? And what can we learn from this, both for some initial service transitions in the immediate future, as well as, unfortunately, preparation for what we would anticipate might be other pandemics in our lifetime? Now, before we get into the qualitative results of our study, of our mixed method study, which Vu will describe in a moment, I would like to share some evidence from our colleagues on the statistical side of our analysis with regard to the impact on HCN-affiliated clinics during COVID-19 pandemic's first year. So next slide, please. There's a saying, as you all are, I'm sure, aware, that if you've seen one community health center, you've seen one community health center. And we would just like to share that this aphorism also applies here with regard to the trend lines as we look at dental service utilization patterns in 2020 as compared with 2019 as a proportion of total encounters across 12 months. As you can see, each clinic has had a unique recovery pattern, some which really have a bit of a plateau at the bottom of service delivery and then a slow rise, others which have a very sharp V-shaped pattern. And so what we seek to do in our qualitative findings today is help to explain some of the top-level phenomena that might explain some of these more clinic-specific patterns. And then eventually we will be merging these analyses into some broader findings in the future. So I'd like to invite Vu to share more about the methodology of the part that we're sharing today, and then we'll come back to results.
Thank you, Sarah. Next slide, please. for this study, we recruited 21 participants from 15 Health Choice Network clinics using a targeted sampling strategy. The HCN research team, led by Dr. Chung, helped us identify potential participants within each clinic based on their roles and provided the potential participants with a study information sheet to help them decide whether or not they want to participate in the study. The individuals who were interested in participating were scheduled an interview with Sarah and I, and these participants did not receive a research incentive. Instead, their clinics were provided with incentives to cover their time, as the participation was within the purview of their role responsibilities. We also collected data by conducting interviews with Health Choice Network dental directors and administrators through Zoom in early January and throughout most of February. So Sarah and I also collected interview data using an interview guide that was developed and approved by the full study team. And the questions elicited participants' perspectives on care provisions during the first year of the pandemic, changing knowledge at different phases of the pandemic, as well as service delivery barriers, and understanding the challenges in facilitators during the COVID-19 pandemic. So all these interviews were conducted in English. They lasted between 30 to 45 minutes each. And before we began each interview, the participants was invited to ask any questions about the study and also gave their verbal consent to participate in the study. The interviews were recorded through Zoom, and we had a third party to transcribe these interviews. The data was anonymized. We also completed a thematic analysis of the interview data, where Sarah and I memoed the notes on emerging concepts throughout the data collection. And once all the data have been collected and transcribed, we independently reviewed all the transcripts, refined initial concepts into initial themes and sub-themes, which we'll share with you later momentarily. We also proposed an initial approach to coding the data as well. After the data collection, Sarah and I also independently hand-coded a sub-samples of these transcripts using initial themes and sub-themes that we've discovered throughout the data collection. And we also addressed any differences between our independent coding as well. After that, we completed final hand coding of all remaining transcripts. We also made minor adjustments to our sub-themes to reflect saturation. So I'm going to hand it back over to Sarah to share our first theme.
Thank you, Vu. Next slide, please. So we came up with 3 overarching themes from the data that really, to us, capture the story of dental health service delivery in HCN clinics during year 1 of COVID-19. And so for theme 1, the providers who we interviewed expressed fear, concern, and distress about the first year of COVID-19, in particular with regard to the pandemic's unpredictability. They were specifically concerned about the safety of clinical interactions, revenue loss, and the potential effects of foregone, delayed, or otherwise unideal care on their patients' oral health. At the same time, providers described how COVID-19 fostered new opportunities for collaboration among clinic staff, within the profession, and with patients and community members more broadly. Importantly, many providers describe these collaborations as deeply fulfilling. We might think of them as a balm through a scary and challenging time. Next slide, please. So foremost among providers' concerns was being as safe as possible in clinical interactions and preventing infection among patients and providers. Providers described their awareness of the unique transmission risks of dental procedures. For numerous providers, this awareness actually preceded federal and professional guidance that addressed these excess risks, and it was magnified by their awareness of the limitations of point-in-time testing. As one provider explained, we have so much airborne microbes going around in the room where you're working. Everything in dentistry is a risk, especially because we're so close. We're dealing with a personal zone. I've always said pre-appointment screening offers a little security, but they're as good as when you take the test, period. Because as soon as you leave, you never know if you got exposed or not. Just go back to when we first encountered HIV. You treat everyone as if they're infectious. That's how we had to do with everything. And I would like to side note here at the end of this quotation that a number of providers mentioned HIV and having lived through that experience. We're not going to go into that in detail today, but for those of you who also had that experience, I imagine that resonates with you. Next slide, please. Another concern was responsibility to patient care. Providers lamented that COVID-related delays in care would prolong pain and suffering, worsen existent disease, delay or disincentivize treatment completion, and ultimately result in more invasive procedures, in particular extractions that they believed should have been avoidable. For example, one provider described being, quote, worried about patients in the middle of care who had started treatment. We were concerned about just leaving folks for an extended time in an interim state, end quote. Another provider explained, patients were extremely happy that something was open. When you're seeing urgent care or emergency patients, these are true emergencies because during pandemic early on, for people who to leave their home and come out, you know they're really hurting. So we had to do something for them. Unfortunately, during the pandemic, because people were putting things off and waiting until they couldn't wait anymore, we're seeing the fomented types of disease, advanced stages of the disease, where they've gotten so advanced that it couldn't be managed in our clinic, but we had to refer them out anyway. Next slide, please. The third concern, as you might imagine, was also revenue. Participants expressed concerns about revenue loss, in particular prior to the passage and implementation of the CARES Act and PPP loan opportunities. Clinics received vastly different federal resources, which in turn affected their capacity to maintain operations and staff at scale. Teledentistry reimbursement was a particular revenue concern as well, given the classification of teleservices as necessary prior, in the opinions of these providers, to adequate guidance on billing. While all providers experienced revenue concerns, some clinics actually found novel ways to recoup income, such as becoming go-to testing providers in the local public sector, and this includes using dental staff as testers. Also, in enrolling new patients who had recently lost insurance coverage and income as a result of the economic fallout and were therefore newly eligible for services in the safety net. Importantly, nearly all participants expressed gratitude that clinic executives explicitly prioritized safety over revenue and trusted healthcare directors and dental directors to determine the balance between infection control and productivity, especially during gaps in materials such as PPE. For example, as this provider explained, every single time that I have a proposal to the CEO of the company, they listen and they provide whatever we need to keep working. That was a really good thing. They understand very well our concerns. Honestly, some days when we're short of PPEs and only see a few patients, they never said anything negative. Next slide, please. Conversely, among the collaboration opportunities that providers described, study participants cited collaboration among team members working at all levels within their clinic as among the most important experiences to get through the pandemic. As one person described, quote, I'm a director, but a lot of these decisions can't just be made by me, end quote. These collaborations involved collective decision-making about everything from service limitations and staffing to infection control protocols, PPE acquisition, physical plant changes, and one of the biggest challenges they encountered, which was case positives among staff. And this provider explained, and this is a long quote, but I'm going to read the whole thing because I think it's worth listening to. This provider explained, very quickly, our organization developed a strong employee health system to where if an employee felt sick, we all knew what to do. Employee has symptoms, don't come in, contact your supervisor, contact employee health. We were lucky to have the rapid COVID testing and address it that way and have people stay home for a couple of weeks and be able to pay them with certain things, processes in HR that were developed where we would have to put in certain codes into their time card so they would still get paid. Then certainly if there was a known positive who was in the clinic and possibly had exposed other people or patients, our chief medical officer and employee health nurse would handle that and do tracking and see what was happening. Were they wearing their N95 while they were here? That was a great thing that we were able to do, and our organization was able to support us with bringing those masks on and making sure that we have them and they're still supplied. If there was a positive, was everyone wearing their N95? Holding people accountable who maybe are not wearing their N95, and then doing contact tracing with patients and see what happened. Absolutely. Then our employee health department and risk manager is going through and following the proper steps and protocols afterwards if there were any contacts, and then testing those who maybe did come into contact. We had that happen plenty of times where you were possibly exposed, We can't tell you who or where or when, but we're going to test you and make sure you're okay. Next slide. Another essential partner during returns to service in the early stages of COVID in particular were the patients themselves. Staff members educated patients, for example, on new protocols that were more burdensome than usual due to other concerns, and then worked with patients on those concerns. As one provider expressed, say, for example, maybe the parent is home with the kids now and not working. So then how do they find childcare so they can come into the office? That's come up every now and then because they can't necessarily come in with all 4 kids. They can only come in with 1 or 2. Then what do we do with the other one? That's the consideration. We try to work with the patients in that regard. Next slide, please. The final collaborative approach that providers discussed in great detail during our interviews was really within the profession itself and their networks. They discussed collaboration with other community health directors in their local jurisdiction or their state, local networks of fellow dentists, including on the private practice side, alumni of the programs they graduated from who are now located elsewhere in the state, country, or around the world. And they talked about PPE, telehealth, and even just the social communion of sharing space and talking about their experience. This also turned out to be practical for patient care. So, for example, as this provider described, the clinic never fully shut down. We stayed open 5 days a week. I reached out to the local urgent care facility, the emergency rooms, all the local physicians' rooms, everyone at the local dentist saying we are here for emergencies, that we do have PPE, and that they could use us as a resource to send patients to us just for that emergency care. Then, if they were with somebody else, we would send them back for their routine care. So that concludes our first theme, and now I'd like to pass it to Vu to share about our second theme.
Thank you, Sarah. The next slide, please. So our second theme focuses on the service delivery resources that were used throughout the different phases of the pandemic to provide care. So as you can see here, 3 sub-themes emerge from this theme here. The first pertains to policy that were either governmental or other professional entities that influence the way the providers have practiced. The second resource is around human resources in terms of task shifting, staff consolidating and scheduling, also temporary furloughs and calling out. And our last resource pertains to material resources such as PPP loans, physical space, PPE, vaccine, and testing. Next slide, please. So at the beginning of the pandemic, many of the providers rely on local and state and national government agencies and other healthcare organizations for guidance around infection control in the clinic while maintaining a positive and professional attitude to continue to provide care. And as the pandemic went on, the guidelines also continued to change, and many of the providers had to quickly adapt to the changes and develop new workflow to accommodate these changes to ensure staff safety and patient safety in the work environment. So as one participant explained here, they wanted to do the best for their patients, for the team, but at the same time, it was the first pandemic for everyone. They continued to talk like, are we doing the right thing? What's the update with the CDC guidelines? What's the update with OSHA? I did my best to try to keep up with all the guidelines. I was trying to get AAPD, APHA, everything. Some of them were based on the same thing, but some of them were different. Some of them were also vague. And at some point, they just said, these guidelines are not mandates, so I'm just going to try to formulate my own versions that will protect the staff and protect the patients, everyone within the scope of the guidelines. We were overwhelmed at first, and we continue to be overwhelmed, but I think at some point, the most important thing to them was actually giving the staff the reassurance that, you know what, we're going to do whatever we can to protect you. We're doing everything as possible to keep you safe. Next slide, please. So here's another example where the provider had to change the way they originally practiced and start to screen patients with COVID. Another provider explained that what is really beneficial for working at a federally qualified health center is that you got this administrative staff in place that really did the heavy lifting on developing policies about how we were going to screen patients. We just recently added the questions, have you been vaccinated for COVID? I'm so glad we were able to add that question. Next slide, please. So the second theme was around human resources, and that played a big role in facilitating care delivery services. Staff changes included task shifting to provide access to dental care, reduce schedules to limit COVID-19 exposures, and also being furloughed until things were back to normal. So task shifting was one of the most used process among all the providers. Every staff member took on multiple roles to improve patient safety as well as quality of care during the pandemic. We had one provider explain that we were cross-training some of the staff members to learn how to do temperature checks and how to do one correctly, and what questions to ask the patients and those types of things. Everyone were assigned to a different task. Before it was just like, okay, everyone knew I'd come in, I'm a dental assistant today, and well, today you may be checking temperatures, but you may be pulling patients as well, and you may be phone triage or dental triage. So everything changed, but it was all in the fact of making sure that we had enough supply and that we had the right material and that the patients were aware of how important it was to not come in if they were sick. So next slide, please. So for other providers, they had to relocate their resources to create a safer work environment. And relocating their resources also meant that they had to consolidate the workspace and schedule to maintain that safe work environment for both staff and patients. We had one provider explain that when team members started coming up positive, what do we do with our workforce? It was at that time we decided that we will assign A group and B group. I'm just using A and B, but we just had groups of individuals that will work together as opposed to trying to fill in, because we will end up with very few individuals to provide this emergency care or just to keep us open. Next slide, please. So most of these providers operate in a multi-site community health center, As the pandemic became more severe, most of the sites had to shut down or move into emergency care only. And this put several sites at risk for closure because it wasn't generating enough revenue, which also led to staff being furloughed. And this was also concerning because most of the patient population these providers treated were low-income working families, and they already have limited access to care. But with the pandemic, it exacerbated the issue even further with limited services and limited staff. Not only it was impacting patient care, it was also affecting the quality of work life among the staff. We have one provider explained that there were significant calls off, particularly the medical assistant, the dental assistants, the front desk operation, and we asked them why. It's because a lot of them are single parents. The schools were closed and there was no child care, and if there was child care, it was really expensive. And the least resistant is just to call off, and by calling off, also put pressure on the other employees that were coming in, and soon they'll fall into the same scheme. Next slide, please. So lastly, our material resources were crucial during the pandemic. We had many of the providers that depended on these additional funding, such as PPP loans and the CARES Provider Relief Fund, to purchase healthcare equipment. For example, the purchase of extra oral suction machines came up several times among these providers. And we have one provider here explaining that one of the things that they really wanted and hygienists wanted was the extra oral suction machines. The problem for them was actually getting it. They were around $2,000 a piece, but with the PPP loans and everything else, the organization was able to get them whatever they need. They have the funding, and they were like, let's get it now. Next slide, please. So another challenging resource among the providers was also physical space. So many of the providers had to limit the amount of physical space within the clinic just to keep it safe for both the staff and patients. We had one provider here explaining that, initially we had patients waiting in their cars and calling us when they arrived before they could even come into the building. So now that's gone the other way. We have a check-in now and just a generalized building check-in where they do the COVID screening and take temperatures before they come up. Then they're given a sticker that they have saying that they were screened, and then they had their temperature taking. So again, just trying to limit the people in the building. So they have to have an appointment to get access to the building itself. Next slide, please. So there was a personal protective equipment shortage across the country as COVID-19 cases surged. Providers were expected to wear additional PPE while trying to conserve the limited supply of PPE. And although there was a PPE shortage and it was challenging for these clinics, some providers collaborated with others in the community just to secure additional supplies to improve the safety of their patient and staff. We had one provider here. They explained that, we've also worked with local dentist societies, and we kept our ear to the ground on all the PPE. And being a community health center here is really important that there are people offering free PPE supplies. So we utilized that when we could get a hold of those free ones. Next slide, please. So as the pandemic carried on, the emergency use authorizations for the COVID-19 vaccine was the turning point for these providers. Many of them were relieved, but they also understood that there was some concerns about the uncertainty and the accuracy of the vaccine among the staff and the patients. So to ease their concern, as healthcare leaders, these providers got vaccinated to promote awareness, education, and prevention about COVID-19. So as you can see here in the slide here, we had one provider saying, right now everything is so new. We have to probably extend some courtesy to these employees who have not yet decided to be vaccinated. And some people take a little bit longer to come on board. And as leaders, this is going to be out there doing the right things. We all can't be leaders, and the followers want to see. And then most of us are followers, and that's why we need to be good leaders to have a good example. Next slide, please. And lastly, as I mentioned, many of the providers were task shifting, and that also meant providing point-of-care COVID-19 testing in the dental practice. And this quote is also very long, but I think it's also worth mentioning. The point-of-care COVID testing in the dental practice. This organization was one of the very first ones to provide point-of-care COVID-19 testings. Individuals were trained by myself or trained by some of our other experts in the lab care facilities. We have had the rapid tests. We've placed them at each one of the larger dental sites and made certain that the training was there. We offered it to patients. They also received a grant, and we also offered it to patients that came in. And I can tell you, we've done hundreds of them because patients love it. So those rapid testings are being done there, then just getting in couples of others in terms of equipment that will reduce the aerosol. That helped them tremendously when it came to starting to treat more patients. And they came in and the patients asked for tests. And they were also just very appreciative of offering this COVID-19 testing. So I'll turn it over to Sarah to introduce our last theme.
Thank you, Vu. Next slide, please. So our final theme is we found that providers, unsurprisingly, anticipate that COVID-19 is changing the future of dental service delivery. Some of the changes they foresee reflect thinking in the broader field, such as strengthening infection control and utilizing telehealth modalities. Other changes reflect current and emergent directions, specifically in community dentistry, including medical dental integration and an emphasis on preventive or minimally invasive dentistry. And then one change really reflects the topic of conversation in broader discussions about healthcare provider burnout during COVID-19, which is providers' experiences of their work as deeply emotional. Next slide, please. Foremost, providers expect the future of dentistry to enact stronger infection control as a result of the pandemic. They anticipate the permanent integration of COVID protocols with regard to patient scheduling and flows, of unobstructed PPE such as level 3 masks, and of equipment such as the use of air purifiers. Importantly, providers recognize that while strengthening these measures is a measure to reduce microbial exposures, it also responds to patient and staff senses of comfort and need to see these measures in place in order to comfortably enter the clinical space. So, for example, as this provider explains, patients are going to want to see providers, assistants, hygienists doing what they were doing during COVID because they're going to expect that psychologically. Patients are also going to have higher expectations. I think we're going to have to meet in the middle on those. Next slide, please. Nearly all providers cited telehealth as an anticipated permanent change in service delivery, and their opinions on this topic varied substantially. For some, there was a lot of reluctance around treatment planning and completion. For example, the notion that even x-rays taken on-site or remotely are inadequate to capture all the necessary information about all dental services. They also have a lot of concerns about reimbursement and patient acceptability in some specific populations. A number of providers also embrace telehealth as a welcome opportunity to strengthen the educational components of their practice. So, for example, brushing technique, flossing technique, even fluoride application, and initial diagnostic stages. As this provider explained, as people have gotten used to that and telemedicine and telehealth in general, I think that demand for it is only going to grow. Once you let the genie out, in other words, you're not going to get it back in the bottle, of course. I think people really do like that, and it's a good tool to have in our toolbox. Next slide, please. In addition, providers were talking a lot about the opportunities that they utilized during the pandemic for collaboration and integration across different components of their community health service center. And this is particularly true for patients, for example, who are diabetic, who would come in for a dental emergency, and on the dental side, they were able to check the A1Cs. Conversely, there was also talk among other providers about some of the oral health services that could be integrated on the medical side, for example, with pediatric patients, geriatric patients, and patients experiencing, for example, homelessness, whose continuous access to care is sometimes mitigated by their life circumstances. So, for example, this provider, whose clinic especially serves populations experiencing homelessness, they explained, we made a decision to give our high-risk patients, whether dental, behavioral, medical, 100 phones, iPhones with telehealth capability from our own money. We made a decision, we selected 100 high risk by the clinicians, and we gave them phones, and we're monitoring the use of it so that they could reach their clinician if they needed to, or the clinicians could speak to them based on the appointment, and the phones are for them for free. We pay for service, meaning the internet that they will call me with. Next slide, please. A number of providers also observed that the versatility with which they solved problems during the pandemic highlighted some of the problems with status quo practices of the past. In particular, as delays in care resulted in the worsening of early stage arrestable disease to the point of requiring more invasive procedures. As one provider explained, we prioritize sealant placement when patients come in for cleaning. Just not dismiss the patient, saying to the parents or the patients, okay, you have no cavities, you can just come back for sealant. The pandemic hit, so they didn't come back until now, and all those molars now have cavities. If we were prioritizing sealants back then those molars would be protected, and we wouldn't actually see those cavities on these teeth. Also, the SDF, silver diamine fluoride application, we started having all the hygienists apply it as well, not just the dentists. Also, we actually do 3-month recalls sometimes as opposed to just our 6-month recall. I really do think that dentistry will have to, and I think it will inevitably turn the focus a little more to prevention. It has to be a continuum of care where it's not just drill and fill. Clean it, yes, but also it's the patient education, like self-management goals, sealants, SDF, whatever you can do to prevent in case anything unexpected like this happens in the world. And finally, next slide, please. Providers almost universally described the emotional experience of serving a dental StationNet population and their staff during a pandemic, and indicated that the acknowledgement of this experience was actually a welcome change from the stoicism that is often expected in the profession. For some, the overwhelming professional responsibilities described in Scene 1 really created the pressure to feel they were responsible not only for preventing transmission among staff and patients, but also extended people in their lives, such as staff's family and patient's family. This external pressure really created a sense of burnout among some and consideration of leaving their position or the field altogether. For others, the experience of directing dental teams through COVID actually deepened their leadership capabilities, even when they felt scared or unsure as their staff did. As one participant explained, December was actually a busy month. I went through my stress with it. I really looked into other job opportunities that would not involve direct patient care. Ultimately, I stayed where I'm at. I'm glad that I stayed where I am, but this summer I was seriously considering leaving. As the year went on, we found that we were safe, that stress, that sense of being overwhelmed went away. And another provider explained to Vu and me, it was just reinforcements too, letting staff know, listen, this is something we've been doing forever. We can do it. We just have to expand what we're doing. We're all going to be okay. You just have to be innovative and try to do what you can for the patient and stay safe and try, like I said, to keep the providers and the staff in a mindset where we're going to be fine. This will work out. The other thing was just trying to be strong, and this provider explained laughing, keep my head in the right place for my family, for the staff, and just be able to stay level no matter what. I could just be like, I don't know what to do inside, but never show that side, and no one knew. Next slide, please. And so I would like to conclude by sharing that these themes, while we present them as distinct in three kind of big buckets with sub-themes, there was actually a lot of interaction among the themes. And so Vu and I want to depart our time of sharing the results with you with this quotation that we think really captures some of the interactions across these various themes, that there was a strong sense of community collaboration and problem solving, that there was a goal of creating emotional circumstances that were comfortable for patients and providers while also implementing stringent safety precautions using a variety of different resources and really innovative resources. So as this provider explained, gowns were one of the hardest things to get a hold of. A women's leaders group here received some sewing machines to make masks for the community. We asked them if they could make us reusable gowns. They, of course, were very happy to oblige, and we paid them a pretty fair price for the gowns. We figured we'd rather keep the money in their community. They sold us about 120 gowns using material that we found that was ASTM level 2 material, which was great. They got it in all colorful colors and everything to make it feel a little bit more fun for people coming into the clinic, not as scary when we're dressed up. And so now I'd like to pass it back to Vu to share a little bit more about our dissemination plans, and then we'll move on to the next component of the presentation.
Yep, so next slide, please. So in the next couple of weeks, we will be putting together a few manuscripts. The first one will be around the information that we share with you today, and we're hoping to submit it to the Journal of American Dental Association. And the second one will be a mixed method study that explains the trends in how safety net dental clinics use teledentistry during the first year of the COVID-19 pandemic. We have also submitted a few abstracts to the conferences listed here, and I'm sure there'll be many more conferences to submit in the future. But right now we are still waiting to hear back from many of the abstracts that we submitted to the conferences, but I know for sure that Sarah will be presenting at the IADR conference this summer. And so now I'd like to turn it over to Dr. Chung and Dr. Shelley Taylor to discuss about the new research that we are working together.
Dr. Taylor, we can't hear you. If you can go off mute. Thank you.
Thank you. Okay, next slide, please. More than 3 decades ago, then Surgeon General C. Everett Koop stated, "You're not healthy without good oral health." In 2000, this statement was reaffirmed in the Oral Health in America report. This report mentioned that oral health is integral to general health and that oral health and general health should not be separate entities. Research tells us that there is a bidirectional relationship between systemic and oral health. Recent efforts to build working partnerships between medical and dental departments is critical to improving healthcare efficiency in the healthcare environment. In the next few slides, I will provide a brief overview of the integrated diabetes care prototype developed by the CareQuest Institute for Oral Health. Next slide, please. As you can see on this slide, oral health impacts many systems in our body. Periodontal disease has been associated with preterm birth, low birth weight babies, and preeclampsia. Delaying dental care during early adulthood is linked to increased risk of having high blood pressure. Diabetes raises the risk of developing periodontal disease by 86%, which highlights the bidirectional relationship between oral and systemic health. Therefore, to help our patients achieve positive health outcomes, we need to seize this opportunity to support more systematic, rigorous, and comprehensive screening and referral practices that promote interprofessional practice. Next slide, please. On this slide, I will provide an overview of the integrated care prototype. So the CareQuest Institute will partner with some Health Choice Network participating centers over the next 6 months to test and refine a predictive analysis process that seeks to identify patients at risk for undiagnosed diabetes or prediabetes, and to identify care pathways for dental staff to utilize an A1C testing system on patients identified as high risk for undiagnosed or prediabetes. Next slide, please. PTS Diagnostics is a point-of-care diagnostic solutions provider who will provide participating health centers with a select number of A1C Now testing systems at no cost to the health center. The A1C Now testing device produces results in 5 minutes, is portable, easy to use, FDA cleared, and CLIA-waived. The dental team will incorporate this device in their daily workflows to administer point-of-care A1C testing. Next slide, please. Health center participants will contribute in 4 areas to support the integrated diabetic care prototype. The first area of involvement is care pathway development. Participants will provide input on care pathway development and infrastructure changes to support prototype deliverables. We will develop workflows from entry to the center to patient discharge, and being certain to include patient referral to primary care if deemed necessary, and patient education on the importance of regular dental and medical services. The next area of participation is with training and kickoff. Participants will participate in a training on how to utilize the A1C Now testing system and also receive education on the interactive relationship between oral health and diabetes. Then, participants will implement the care pathway design, will collect data, and participate in prototype activities over a 6-month period. And finally, we have data collection. Participants will provide quantitative and qualitative data through surveys, check-ins with the CareQuest Institute, and data reporting to capture participant experience. Through these processes, we hope to spearhead the expansion of oral health and primary care integration within our health centers. Each year in the United States, an estimated 27 million people have a dental visit, but not a medical visit. Thus, dental visits provide a unique opportunity for screening, counseling, and referring individuals for prevention of chronic diseases. By screening patients for diabetes in the dental office and referring patients who are at risk for developing diabetes to their medical provider, sooner rather than later, will help provide and improve patient health outcomes. Next slide, please.
Okay. Thank you very much to Dr. Taylor for providing information on a project that is in the planning stage and in which health centers have the opportunity to participate, which looks at how oral health can predict the risk of diabetes incidence. Thank you very much to Dr. Raskin and Ms. Dieppe for presenting the completed research project, which sheds light on the resilience and compassion of our health centers in providing oral health services in light of COVID-19. Right now, we have an opportunity for questions. Asking any of the participants, if you have some questions, please put them in the question box for us. But this is a nice opportunity to have some question and answer period. So the first question is for Dr. Taylor. Dr. Taylor, are there any special requirements that health centers must meet in order to participate in the project that you shared, such as volume of patients, the location, et cetera?
Thank you for your question. So yes, there's some specific requirements to participate in the prototype project. First, the health center needs to be CLIA waived, and also the health center needs to be located in a state that the dental, the Board of Dentistry allows for the point of care A1C testing to be done by the hygienist. So those are the main criteria to participate in the study. And I would say it's important to also have a large number of diabetic patients. So that's something, because we really want to test the workflow. So that's something very important to really consider as well.
Excellent. Thank you so much. The next question is for Dr. Raskin and Ms. Dieppe. As a result of the completed research study, what are some questions that came up during this study which you think would be interesting for future research?
Sue, would you like to begin and then I'll jump in?
Yeah, so one of the topic that I'm interested in for further research is teledentistry. We noticed that some clinics did use teledentistry after, or actually during the COVID-19 pandemic, but we wanted to see if they were continuing to using it and how it's impacting their care right now. So that would be something that I'd be interested in. And then Sarah?
Sure. So I'm also interested in a topic related to teledentistry, which is really about a flexible workforce that uses practitioners practicing to the top of their license, regardless of what they are, whether they're dentists, dental hygienists, dental technicians and assistants, et cetera. And thinking actually about that as a concept in pandemic preparedness, should we have to encounter another pandemic like this, and figure out some flexibility in that. I'm also really interested in state variation in terms of policies with regard to shut down, open up, and then also the distribution of essential material supplies like PPE and testing.
Perfect. Thank you so much. The next question is for Dr. Taylor. Dr. Taylor, what phase is the diabetes prototype project?
What phase, meaning what phase are we in right now? Are we basically are we selecting the health centers? I'm trying to understand the question.
I think that might be it. I'm wondering, this is a question from Dr. Washington Oates. I think, can you, Dr. Washington Oates, if you're there, can you clarify? Is it maybe about like clinical trial phases, that type of thing? Is that what the question is? I'm not sure. Versus, you know, where the project currently is.
Okay,
Yeah.
well, I could talk about where the project currently is. So the kickoff call would take place within a couple of months. So health centers were selected. So certain health centers were notified of their participation. So that's where we're at right now. We have not started actual clinical workflows right now. So we just selected the health centers, and then we're going to start with the educational process.
Excellent, thank you. Okay, there's another question, which is, okay, so this question is for Dr. Raskin and Ms. Dieppe. In the research study, did you notice worsened outcomes among substance users and those with mental problems? So did any of those issues come up? Working, you know, the health centers working with these particular at-risk individuals, people who use substances or have mental health issues.
So maybe I'll go first, Sue, and then if you'd like to share your thoughts. So we did not do an outcome study on the qualitative side. We are describing the phenomena of delivering care, but certainly issues surrounding mental health and coping mechanisms on staff came up as a concern, for sure, to make sure that staff were taking care of themselves and being taken care of well by those around them. And then also, we are collaborating with our colleagues who are working on the statistical analysis that is looking at outcomes, in particular claims and utilization data. And we would anticipate, unfortunately, that people who have comorbidities probably suffered worsened health outcomes long term as a result of some of their home hygiene considerations. At the same time, the kind of optimistic story here is that the providers talking about integration across behavioral, medical, and dental in community health centers that can provide homes for all three of those things do create opportunities, possibly for the future, for providers to screen in more immediate and urgent cases, perhaps through tele or otherwise, and then be able to deliver care to them on site. I know that nationally there's a lot of examination right now about outcomes during COVID, and I imagine we'll see literatures on these things coming out pretty soon with some longitudinal data of when folks are able to cycle back into the clinic, that kind of thing. Yeah. Do you have any other thoughts on this?
No, I think you covered it all, but I will just put in a plug that we did also at CareQuest Institute did a survey for patients and consumer, and we just put out a brief yesterday about the connection between oral health and mental health as well, and that it has that piece on opioid as well in there too. So if you guys want to check that out, that is available on our website.
Excellent. Thank you for that. And you know that is such a unique component of our health centers, just the interdisciplinary model and the fact that there is so much opportunity for all the different specialties to come together, for the benefit of the patient. And where else can you do that but our community health center? So that's such a great opportunity there. We are running out of.
Just one more tiny point on this.
Of course.
I do want to say that our participants were so sensitive to how pain management at home, especially through prescribing opiates, really it kind of broke their heart to think about doing that as a longer term strategy, and they were deeply sensitive. And so I do think that developing guidance in that area is going to be a really important opportunity for health centers to contribute to the broader field of dentistry long term.
Perfect. Thank you so much for that. So we are running short of time. I think the last question will be for Dr. Taylor. It's really two parts, which I don't know how much time you'll have to really answer, but what are the expectations of agencies that partner for the project? And the second, are you still accepting agencies to partner?
So those are great questions. So I'll try to be quick. So the expectations is basically we're looking for agencies who are motivated and really understand the importance of oral and systemic health and the connection between the two. And so the expectation is we will want to have a clinical champion on both the medical and also the dental side, so we could have the referral between both departments to really assist our patients achieve like holistic care and whole body care. And so we're looking for, I would say, a health center who definitely uses a hygienist, and the hygiene department is well developed, that's able to incorporate point of care A1C testing within their workflow, so it wouldn't be a burden for them. And also a health center who has, I would say, interdisciplinary care team lead in the medical side to assist with that referral process. With, I would say, accepting new health centers, I am unsure of that answer, so I don't want to answer that right now. But if you will, just email me the information of your health center and your interest, and we could possibly see if we can include your health center within this prototype project.
Excellent. Thank you so much for that information. And with that, it has been an honor, a pleasure to have these opportunities. This is the third dissemination research roundtable that we've had with you all, and you've been gracious with your time. The projects are amazing, and we feel like, you know, in you we have a like-minded partner who is very motivated and caring about our community, and we can really do some great research which will shine a light and help us to understand how best to serve our patients. So thank you very much for the work you're doing. Thank you for the partnership. We look forward to many more projects with you. And we will continue to do this meaningful work with our health centers. Thank you again to Dr. Raskin, Ms. Dieppe, and Dr. Taylor. I'm asking all participants, please, there's a survey that you will get prompted as you exit from the seminar. We ask that you please complete the survey. And with that, we wish you a wonderful, great evening. Thank you so much.